Hi, everyone. Today we'll be talking about the ethics of vaccine distribution. This should be a pretty straightforward presentation, quick and easy to understand. First, for some background, the COVID-19 pandemic has infected at least 19.9 million Americans, with 344,000 deaths since the start of the pandemic. And basically, it's been straining communities, families, and the larger healthcare system as a whole. And we've personally seen the increased demand for lab testing, personal protective equipment, hospital beds, and treatments throughout the last few months. And now some hospitals are also struggling with rationing healthcare. Now, arguably, the most important game changer when it comes to combating the pandemic is the vaccine, and it may prevent infection for millions of Americans. But the distribution of the vaccine is what remains controversial because demand for them is high, and currently in the beginning of the vaccine approval process, the supply is low. And from the last numbers that I saw, 2.1 million doses have currently been given out, with approximately over 11 million that have been distributed. But to provide some context, our country has 328 million Americans. So, sure, not everyone will get vaccinated, but the rollout process has been going through with a limited supply of vaccines compared to the population. So the question becomes, in this sort of environment, in this climate, how do we allocate healthcare, specifically this COVID-19 vaccine, when healthcare is finite, when our resources are finite? So, to provide a little more context, Operation Warp Speed has been one of the major federal responses to the COVID-19 pandemic, and it works with the private sector to really develop the COVID-19 vaccine. So, on December 11th, 2020, the FDA had issued the emergency use authorization, and that had approved the Pfizer vaccine. And then, about a week later, Moderna was similarly approved. And so now those two vaccines have been a part of this rollout process. And since then, weekly allocations of the vaccine have been distributed, and they've been all through an FDA safe manner. On the 27th of November, the CDC had actually released this morbidity and mortality report. And basically, in that report, it outlined the Advisory Committee on Immunization Practices, their four principles that they used in determining how vaccines should be really allocated. So these are ethical principles, and those principles are maximizing benefits and minimizing harms, promoting justice, mitigating health inequities, and promoting transparency. The benefits of vaccination, they happen on both the individual and societal level, so community level. Individuals themselves, they have obviously a lower risk of contracting COVID-19, so it reduces their individual morbidity and mortality. The community, of course, is also indirectly protected because now there's a smaller population that can actually get infected, and afterwards, herd immunity can eventually also be used to actually protect individuals who might not be able to get vaccinated. So often when considering, how should this vaccine be distributed, the greatest number of deaths prevented is often what's considered when actually discerning who actually gets a vaccine first. But that's not necessarily the only way to look at it. You can also see the number of years saved in a person's life and use that to determine who should actually be getting the vaccine first. Another concept you'll hear about, what is the most fair solution? So when considering that, a lottery system is actually what gives every American the equal chance of getting a vaccine. But really, it doesn't necessarily happen in reality. Vaccine distribution is not really given out based off of what's most fair, but actually also depends on what provides really the most benefits that balances both the individual and society. So fairness is basically considered with regards to both the outcomes of having the vaccine and also, of course, taking into account the chances of receiving a vaccine. So this goal really requires a discussion on values regarding, who benefits the most individually from the vaccine, who will actually be able to access the vaccine, and who would provide the most benefits as well to society with their vaccination. So one population group, of course, comes to mind, and currently in the rollout are healthcare professionals receiving the vaccine. So they would receive, of course, the individual benefit of vaccination because they end up having an increased risk of exposure to COVID-19, but they also have a significant societal impact because potentially healthcare workers can serve as vectors that can actually transfer disease over to patients that have particularly elevated risk of having severe COVID-19 infection. And so for that reason, there's a little bit of a crossover with both the individual and societal benefit that's increased by having healthcare professionals vaccinated. However, after that, the challenge becomes a little bit more in deciding who should actually get vaccines. Sorry, phone went off. And when considering what happens next, the CDC has recommended that first the vaccines be given to healthcare providers, and then nursing home residents also come in that first batch. There is no formal federal plan aside from allocating the vaccines to the state, and then on a state-by-state or local level, it can be determined how the vaccines should actually be distributed. So here in Nevada, for example, it's done based off of stratifying individuals by their risk, and so the different tiers are comprised of different population groups that the state has determined have a certain level of risk of contracting severe infection or COVID-19. So with global considerations, the COVID-19 virus, of course, has caused a pandemic, and this has spanned across nations, not just here. And so far beyond a local demand, there's actually an international demand. So due to the scarcity of the vaccine, now there's also this disparity between developing nations and developed nations that where developing nations might be especially vulnerable to getting COVID-19, and that's really because potentially of the difference in resources, lack of available diagnostic, treatment, and preventative measures that might be more possible in developed countries. Also, due to the fact that the private sector is, of course, driving vaccine development, it's largely possible that wealthy and more developed countries will have larger numbers of the vaccine because of that developed private sector. And so because these countries are developing, many times they might be investing their own resources in vaccine development. Countries are incentivized to really develop the vaccine in this capacity of vaccine nationalism, which is really this idea that countries will have this obligation of providing the vaccine first to their own citizens. But then the question becomes, how do you allocate the vaccines after enough of your population has been vaccinated? So when considering the US, will they really be distributed based off of the frameworks that are that we're going to talk about, or will it be based on need determined by economic constraints, or really are external political factors really going to be driving this effort? So the allocation of the vaccine might be driven more by what incentive the US actually has to give the vaccine to certain countries. So taking into account like who their allies are, what strategic partnerships could be, and even the geopolitics over other potentially ethical concerns. So there are a few different programs that we can talk about. The COVID-19 vaccine global access program is led by the WHO, the Coalition for Epidemic Preparedness Innovation, and Gavi. So that collaboration, based off of that, vaccines would be distributed by need based on population size until about 20% of that country's population is vaccinated. So contributing countries or non-contributing countries would really only receive vaccinations for their essential workers before donor countries are able to reach that 20th percentile, that mark. And this raises ethical concerns because for a lot of the countries that might be non-contributory, they might have the greatest need for these vaccines, but only 3% of their population would be vaccinated at that point. So that's one potential issue. Another proposal by the WHO would prioritize the vaccine distribution based on the country's number of essential workers, how many elderly there are over 65, um, and also which patients are the most vulnerable to have serious infection. So that's a potential other way of triaging who should get the vaccine. The fair priority model, it states that after countries are able to control their own virus, the vaccines can be distributed to countries in the way where it would save the most number of life years. So it would take into account things like disability, poverty, and economic damage that the vaccine could prevent before taking into account issues like reduced transmission rates. And then lastly, there's another thought where researchers from Vanderbilt suggested scoring countries based on the capacity to provide care, the ability to distribute vaccines, and then also the contributions towards testing and developing new interventions. So naturally, all of these models really would incorporate this idea of vaccine nationalism, where countries that were more directly involved in the investment of resources for vaccine development would end up having likely greater access to these vaccines. Regardless, this whole issue has been complicated by the issue that the US has withdrawn from the World Health Organization. So it's likely that international collaboration and cooperation in the upcoming year is probably what's going to be driving the decisions surrounding vaccine distribution. But perhaps, so prior to even considering these global issues, the first priority for the US government would be the vaccine distribution for Americans. And so the challenge has been really further complicated by some external factors. So really the difficult political environment, which has politicized a lot of the preventative measures like wearing masks and vaccines, the existence of the virus itself, the polarizing election year has really fostered this lack of unity in the response to the pandemic. And so causes a lot of mistrust potentially in the healthcare system and also the government. So I think this requires careful thought as to who actually receives the vaccines first. So the question is, should essential workers be prioritized first who might have to attend to their jobs, or should those who are at highest risk be vaccinated first, highest risk of dying really from the disease? And then you can think of other things like, does location matter most with the population dense areas requiring immediate action? And these questions are, of course, valid questions to think about, but also along the lines of defining what the terms even essential workers and highest risk even mean. So which population groups would actually be included in those? And that would impact who actually gets the vaccine first. So essential workers may be hospital employees and they might work directly with COVID patients, or they might be grocery store workers that make food distribution possible. But broadly speaking, they're basically anyone who works in a position in our society that really society can't function without them. And that's really a broad definition of what could be considered an essential worker. And so the definition for vaccine purposes would just require that people be further stratified based on issues that balance their personal risk with societal impact. There are also high-risk individuals, and defining that is in and of itself is a task, but they might be people who have multiple comorbidities, or they might be the elderly or immunocompromised. So it could be that we should prioritize this population group because you would be saving a large number of people, considering that COVID infections are incredibly severe in these groups. And so current estimates have also been published that state the vaccination is most cost effective if it's targeted at groups with higher risk of hospitalization and death. And so that tends to happen in groups like the elderly. However, it's still important to think about the youth population because, for example, even young people, they might carry long-term consequences of getting the infection, and they might not be present initially on acute infection. So these long-term impacts, they're significant in considering that young population in the US, they provide like a large economic benefit because of the years that they can contribute to society. But just because they have a lot of life years that they can contribute to society, it doesn't mean that, for example, people who are disabled who might contribute less life years simply shouldn't be prioritized. That shouldn't be the case at all. So also, when thinking about these sorts of ethical decisions, lots of times we focus on health, but vaccination doesn't only impact a person's health. It's not necessarily in a vacuum. So, for example, with the youth, while schools can be closed and that would prevent the need for vaccination, um, a student's educational opportunity is actually also hindered the longer you have school closed, and maybe that could be considered unfair for a long-term child's development and opportunities. And then another point to consider is that young children might have the ability to be super spreaders. So this is seen with the influenza pandemic previously. So of course they did not necessarily die as high rates, but they were super spreaders of infection that caused higher mortality to people, to population groups that did have that elevated risk. So then the question becomes, would it be more strategic, more effective to vaccinate people who make the virus highly transmissible? So basically, people who have a lot of contact points, like these kids, over individuals who might benefit personally the most, like groups like the elderly. So that's another potentially, important question to think about. And lastly, other groups that are, of course, very disproportionately impacted. So, as stated by the national academies, an equitable allocation of vaccines in the US and worldwide would take into account the disproportionate impact the pandemic has on those people who are already disadvantaged by race, ethnicity, age, health status, residence, occupation, socioeconomic condition, or other contributing factors. So it has been a fact that the nation's poorest minority populations communities have really borne the brunt of the pandemic due to unfavorable social determinants. So influenced by issues like structural injustices, health inequities, we see people who are incarcerated or the Black, Native American, Latino communities really disproportionately affected. So when considering, who should actually be able to get vaccines first, we have to consider the individual and societal benefit of providing vaccines for populations that have been disadvantaged. So while we've been talking about the frameworks, you have to wonder what ends up actually happening in reality. And I think that this is the interesting part where there have been a lot of vaccine rollouts that have been occurring on a state-by-state basis, and so there have been concerns about previously the wealthy and the well-connected and the idea of corruption. So during the pandemic, people who were well-connected and wealthy, so people who were politicians or athletes, were able to get access to newer therapies and even just lab testing. COVID tests have been in short supply for a long time. And other average Americans were unable to get the same level of care and same level of resources. So when considering the people who are wealthy, well-connected, or even just involved in the control of money and institutions, there's a concern that they would be able to jump their place in line due to their ability to pay either for the vaccines or influence the flow of money in an institution. So there might be ulterior motives, basically. And so the reason or the way that this kind of can manifest is having the rules bent when considering, who is defined as essential in the workplace or frontline worker. So these can be very broad definitions potentially and might be influenced by lobbying firms or even pushed against by patients pressuring doctors to give them vaccines. So further down the road, there have also been concerns for bribery, theft, and even a black market when vaccines that, for example, won't require this ultra cold storage and technology. Without that, those might end up occurring, more bribery, theft. So right now it's thought that the optics of cutting your place in line, it's a social shame, is a deterrent for this vaccine, like maintaining the ethical guidelines and frameworks for that vaccine rollout. But in the future, this might not be the case, and there are already many stories of, for example, healthcare providers working directly with COVID patients or having COVID exposures, not getting their vaccines before people who might be managers or coordinators without any sort of patient care. So, considering all of these issues, it's important to keep in mind these ethical frameworks and also see what ends up happening in the future during this actual rollout. So the COVID-19 pandemic, it's really created a unique set of demands on just the healthcare system, the economy, and the government. And so it's led to some really interesting things. So the fastest ever vaccine development, but also subsequently there have been ethical concerns with its distribution. So although the development of the vaccine is fast, its implementation has been a struggle because of the increased demand for the vaccine over its current supply. And so, because of this, leaders in both our healthcare systems and government have had to judge how to allocate a finite resource that would provide the most benefits to individuals and also society. So while the system really has not been perfect, the vaccine itself has brought a lot of hope to millions of Americans across the country. So we'll continue to wrestle with these ethical implications of the rollout until really the supply of the vaccines end up matching demand. But I found this topic really interesting. I hope you did too. It's a very brief overview. Thank you for listening. My sources are here on this page, and I can't wait to be doing more of this stuff. So thanks for listening.